I'm Robert Stiles with Telehealth Rocks, and we appreciate you coming to today's session. We want to go ahead and get started so that everybody, we have time to get through everything today. Just a few reminders before we get started. The session is being recorded and will be available along with resources and other items will be sent out after today's session. Sorry, just one second. Not very good at multitasking. Please leave your microphone's been muted. Please leave it muted unless you have a question, which are always welcome. And you can also put your questions in the chat. We like for people to leave their camera on so that we can be a group as we discuss things and do things, but we understand you may be in a place or location or in a situation where it's not ideal to have it on. We will be sending out certificates after each session. And it's very important if you look at your name on the screen that you take the chance to change it to your first and last name if possible, so that we'll know who attended and can send out those certificates. And then wanted to introduce today's leaders of today's session. We have Dr. Emily Goodwin, who is a pediatrician at Children's Mercy here in Kansas City. Dr. Timothy Ryan Smith, who's a pediatrician at the University of Kansas Health System, both of whom work with medically complex patients. And Dr. Dana Bakula, who is a pediatric psychology fellow at Children's Mercy here in Kansas City and will be our presenter today. So excited to have everyone, and want to pass it on to Dana to get us started.
Thanks, Robert. Okay, so we will run through some introductions and disclosures, have our didactic presentation today, time for questions, our case presentation led by Deborah Birdwell, who's graciously agreed to present a case today that we're excited about, and then some group discussion about that case. Next slide. And we do not have any relevant financial disclosures to share today. And the information and recommendations involving clinical medicine is based on evidence that is currently accepted within our profession. And after this session, the slides and recording will be sent to all of you as they are processed. Certificates of attendance will be sent out. And if you have any questions, feel free to email the Telehealth Rocks team with their email on the screen here. So our objectives today, we are talking about accessibility for children with medical complexity. So we will be able to define accessibility, describe barriers to accessibility for children with medical complexity, and identify at least 3 ways you can promote accessibility for children in your professional setting. And again, I just want to bring it back to our aims of this kind of overall spring series, which is focused on social determinants of health among children with medical complexity. We know that societal factors impact an individual's health regardless of age, gender, race, or ethnicity, and these social determinants of health are incredibly important to the well-being of children with medical complexity and for all people. Next slide. And we see that social determinants of health really span from every area of a person's life, ranging from economic stability, education, access to food, healthcare systems, community and social context, and that our social environment in all of these settings really impacts health outcomes for all people. And there are some particularly important ways that it impacts children with medical complexity that we've touched on and really just skimmed the surface during this series, but hopefully have shined a light on some important topics. Next slide. And today, like I said, we'll be talking about accessibility as a really important topic within this social determinants of health series. But first, I want to kind of pull back and think about disability terminology and how this applies to children with medical complexity, because I think it's a really important thing to understand when thinking about accessibility for this population. So children with medical complexity also have disability status. And so the Americans with Disability Act defines a person with a disability as a person who has a physical or mental impairment that substantially limits one or more major life activities. And so children with medical complexity also have disabilities, and it's really important to understand the background of what that comes with and how that impacts their life and their experiences. So I want to talk a little bit about disability first. Next slide. And in doing that, I want to just give a very brief and very abbreviated history of disability in the United States and also a little bit more broadly to really understand how recently some major changes have happened for people with disabilities and put that kind of in context when we're thinking about accessibility currently. So in the 1200s to 1700s, people with disabilities were not welcome in hospitals and shelters, and they were forced to be on the streets. In 1850, we saw that the eugenics movement began, which involved institutionalization, asylums, and forced sterilization of people with diabetes. And as recently as 1927, which was just about 100 years ago, the Supreme Court ruled that forced sterilization of people with disabilities was not a violation of their rights. And then it's only been as recent as 1963 that we saw President Kennedy call for reduction of institutionalization, and as recently as 1965 that Medicare and Medicaid were established, which is a service that cares for many of our individuals with disabilities, and 1990 when the Americans with Disability Act was passed. So I say all of this to just kind of contextualize the history of disability rights in our communities, to really understand that many of the things that we see today are relatively recent in the grand history of disability rights. Next slide. So in pulling it back to our discussion of accessibility today, accessibility is defined as the quality of being possible to get into, use, make use of. And what that means is it's the ability to exist in environments and use the resources in them and access them in a reasonable way. And accessibility is necessary for inclusion, right? So in order for people to be included in community spaces, in education, in healthcare, in housing, there has to be accessibility of that environment in order for people to be included in those spaces. It's also really important for equity. So in order for us to be fair, impartial, even, and just, we have to have accessibility for all people to be able to access the same spaces and the same opportunities. Next slide. And pulling this back to accessibility and how this relates to social determinants of health, I think accessibility is a really critically important to all social determinants of health. And when you look across the spectrum, ranging from education, we know that accessibility, as Judith Heumann talked about in her talk, is critical to being able to access education in the same way, to accessing community and social spaces like playgrounds for children, like accessing healthcare systems, opportunity to different jobs, and how that impacts economic stability. So really, accessibility is this cross-cutting issue for individuals with medical complexity and with disability that has a really powerful impact on their well-being. And we see that all of these different facets are really critical to health outcomes and well-being, which is why we care so much about them. Next slide. And unfortunately, ableism can be a huge driver of lack of accessibility, and ableism is the intentional or unintentional discrimination or oppression of individuals with disability. So as a result of the social constructs that surround disability, children with medical complexity may experience adverse consequences due to ableism. And this idea that people with what we consider to be typical abilities are superior, and that individuals with disabilities are inferior or are the ones with the problem and not the rest of us in our social environment. Next slide. And the social model of disability does a great job of really talking about and describing some of the ways that our world is not set up to be accessible for individuals with disability, and kind of flips the notion on its head of what accessibility means and what our world looks like. And so there's a lot to this model, and I would encourage you to read more about it, but just kind of a glimpse into the different ways of looking at individuals with disability from our traditional and longstanding medical model versus the social model. So this picture has an individual in a wheelchair facing a set of stairs saying, "Everyone's welcome, come in," but no way to navigate up the stairs. And our traditional medical model might say, right, the impairment's the problem. We need to find them prosthetics or a cure or solve the disability. Whereas the social model would say, the stairs are the problem. There should be a ramp and there should be accessibility in all of our environments to allow people equal opportunity. Next slide. And thinking about equity, right? So I said that, we need this for equity. We need to have these environments that allows individuals with disabilities to participate equal and to access things the same way that others do. So this is an image many of you have probably seen before, right? So equality is giving everyone the exact same thing, and that means that some people can participate and others cannot, whereas equity is providing everyone the thing that they need in order to access that environment. And then this model also takes it one step forward, looking at justice as removing the barrier to begin with so that everyone can participate equally. Next slide. This is another great example that Dr. Goodwin shared with me on equity and what it means. And I think, again, is a great image to really think about how accessibility impacts equity. So we see in the first image, everyone gets the exact same bicycle, and that bicycle really only works for one individual. It's too big for one person, too small for another, and is not possible to be ridden by the person who uses a wheelchair. And then in the second image, the equity image, we see that everyone is provided a wheelchair that fits, or a bicycle that fits their needs, and that creates more equity in that environment. So again, this is really where we see accessibility making a huge difference on equity in our environments. Next slide. So when we think about accessibility for children with medical complexity and what some of those barriers are, they can exist in our physical environment, so limited access to ramps, or wide doorways or playgrounds in our environments, limited access to adaptive technology to meet the needs of children with medical complexity and allow them to participate fully in those settings. Our communication environments can have barriers such as not using sign language or image descriptions or Braille or communication devices and not having access to those things, preventing children with medical complexity from participating fully. In educational settings, it can look like not identifying accommodations that are needed for individuals or not using those accommodations consistently in all settings, in all classrooms, and resulting in that child not being able to access the education environment fully. It can look like using ableist language or talking around children with medical complexity as if they're not there, they can't hear us or understand, or underestimating their ability to participate and alienating them through the language that we use. It can look like neglecting children with disabilities when developing policies or protocols, or even designing community events without them in mind. All of these can be barriers to children with medical complexity participating fully. Next slide. I pulled these recommendations for accessibility from the Job Accommodation Network. And so this is a broad list of recommendations to promote accessibility for individuals with disabilities, and includes things like having accessible spaces with doorways, ramps, bathrooms that are all accessible, using visual and non-visual formats, using sign language and written language, avoiding ableist language in our speaking, avoiding lighting that can interfere with some disabilities, such as fluorescent lighting, strobe lighting, or flash photos, having accessible restrooms that allow people with a range of physical abilities, genders, and places where people who require an aid to accompany them to the bathroom, that there's enough space for those things. Having quiet spaces for individuals with sensory sensitivities, offering paratransit options, live streaming and recording events to allow people to participate virtually, and offering written materials to supplement spoken materials. So these are all ways that we can create more accessible environments in our world. Next slide. And when thinking about what do we do, what do we have the power, each of us, to do to advocate for children with medical complexity in our own settings, I've got a list of ideas here, but while I'm talking about these, I'd love to hear in the chat what you've seen in your settings to advocate for accessibility with children with medical complexity, or what you'd like to see in your own settings. I'd love to hear from any of you that have seen this or have ideas about this, but some of the small ways that we can do this for the children with medical complexity that we work with include familiarizing ourselves with disability rights issues in our communities, and knowing what's going on and knowing what issues are present. Asking the children and families that you work with about barriers that they face to accessibility, to familiarize yourself with their concerns, and advocating for accessibility, inclusion, and equity in your spaces, in your settings, in your communities. Empowering children and families to advocate is also a huge one here. So they are the experts in their own experiences, so the more we can empower them to advocate, the better. Considering universal design when creating new initiatives, and universal design could be its own separate talk, so I won't dive into it here, but I would encourage you all to look into that more. Advocating for comprehensive 504 plans and IEPs for those of you in school settings, and again, ensuring that those are consistently implemented to meet the needs of children that you work with. Using person-first and accessible language, and treating children with medical complexity with respect and dignity. So these are just a couple of small ways. I'd love to hear in the chat, or feel free to unmute yourself if you have seen or have other ideas of things you'd like to see in your setting to address accessibility for children with medical complexity. Maybe nobody has, oh, I see Deborah said, need more apartments that are accessible. I agree. I think housing is a great, is an area where we have a lot of need to increase accessibility, especially in more kind of rural and more spread out areas in Kansas. That's a great point. Thanks for bringing that up, Deborah. And if you have other ideas as we keep talking, feel free to share them, but I'll keep moving through our presentation. So next slide. So I just wanted to summarize the three-part series that we've gone through this spring on social determinants of health when we're coordinating care for children with medical complexity. We have really just kind of scratched the surface of these social determinants of health. And I hope that the things that we've talked about have been of good use to all of you, and that we've shined the light on some important topics. We've covered working with refugee and immigrant populations, health literacy, and accessibility for children with medical complexity. Although again, as you see in this image, there's so many social determinants of health that impact all people, but have really special impacts on children with medical complexity that are important to think through and understand when working with these children and families. So I just want to kind of summarize those things, and thank you all for participating in this ECHO series this spring.
Dana, I did want to call out Janice Stuckey commented on her experience in accessibility, and talked about a theme that's been common in our sessions about the distinction between 504s and IEPs. And she says that in my setting, accommodations and modifications are provided for both 504s and IEPs. However, these two items are often confused. I think that's a good call out to understand those kind of tools that they use in the school setting to address such issues.
Absolutely. And Janice, I'm glad you brought that up. I think a lot of people struggle to understand the difference, even people who may see them frequently in their settings, and may interchange or misinterpret their functions, right? Whereas the 504 plans really come from a disability and accessibility kind of framework of allowing children with disabilities equal opportunities, whereas IEPs are about individualized education plans. And I think also understanding the historical context of where those came from, the pieces of legislation that they came out of can be really impactful. We did in our ECHO series last spring, that should all be archived on the website for Telehealth Rocks, cover IEPs and 504 plans. So for anyone who finds similarly in their setting to be struggling with those, it could be worth pulling that back up or sharing some of those resources that we shared last year with your colleagues. So thanks for bringing that up, Janice. And yeah, Ryan, thanks for bringing that to my attention that was in the chat. At this point, I do want to pause before we move forward with our case presentation to ask if there are any questions or pieces of wisdom that people want to share from their own experiences with children with medical complexity, particularly around accessibility, or even other questions about any of the other topics that we've discussed in this ECHO series this spring. And thanks, Christy, for putting up that resources slide, which all these resources will be sent out to all of you. So I'm going to pause here just for any questions that we may have. Okay, well, if there aren't any questions, I'm happy to move forward because I think we have a really interesting case presentation today. So Christy, if you want to advance to the next slide. Oh, go ahead, Emily.
Yeah, I was just going to say, this has been really fun for Dana and Ryan and I and the ECHO team, and we really appreciate you participating. We also really, really value your feedback and want these sessions to be useful for you. We're excited to get into the next part, which is our case presentation, and encourage you to bring questions forward. But we will also be sending out an evaluation you'll receive in your email. You'll get one today, but also and if we'll have a follow-up in a little while, in a few months, to kind of touch base as well. So we'd love to hear ways we can improve the series, what you liked, what you didn't like, and any potential benefits you found from it, so we can continue to improve and in thinking for our planning